Hi everyone, I'm Sam Mazzeo, PGY2 AMIM. So I'll try to be quick just because we're short on time. But this is my pulmonary small talk about hypotension following intubation. So a quick thank you to Drs. Chu, Kopchuk, Douglas, and Turner for helping me prepare this lecture. So imagine you're in CCT, patient comes in, respiratory distress, and ultimately they need to get intubated despite any other measures that you attempt. Obviously, there's a lot of potential causes that can cause respiratory distress. And shortly after you intubate them, they get very hypotensive, like 80s over 40s. So my approach in this lecture is to go through a little bit of the differential, but think in that moment, like, what are you gonna do? This patient will crash and go into cardiac arrest. You don't figure out what's going on and try to stabilize them quickly. So really fast, our objectives, like I said, discuss a little bit of the clinical presentation and a quick bedside approach to diagnose the possible cause, as well as some emergent or stabilizing treatment for each of these diagnoses. Rebel EM has a good mnemonic if you're a mnemonic type of person, an Oshite mnemonic. So here is a list of them, and we'll go through each of them briefly. So again, that you intubate someone, hopefully you have a decent amount of history to kind of gauge what might be going on, but unfortunately we're not always that lucky. So I asked you again, what are you going to do? And I just really wanted to include another meme because this show cracks me up. So hopefully the first thing you're going to do is run over to the patient and examine them, okay? You have a lot of things at your disposal, and hopefully everybody's walking over, great, or hope maybe running if need be, but walking over super confident, you're gonna figure this out. Even though on the inside you might be feeling like this, which is usually how I feel in CCT. But you have a lot of things at your disposal. You have a lot of tools that you can use. Most importantly, examining the patient, look at the monitors, look at the vent, use your stethoscope, listen to their heart, listen to their lungs, and you always have ultrasound, at least here. You might not always have it at other facilities. So, but ultrasound can be a very useful tool, especially in some of these diagnoses that we'll go over. If you're lucky, you might have labs and you might have other imaging, but I wouldn't count on it. Here's the list of diagnoses. I kind of made this table just to categorize each diagnosis, what I thought a quick diagnostic test would be, and quick treatment. I'll just say, if it's not obvious, each one of these diagnoses could be an hour-long lecture. There's fellowships dedicated to certain things like pulmonary hypertension. I'm obviously not going to go into like deep dives about everything. It's more of a brief overview. So this is what I briefly thought of. Every single thing you're going to have hopefully some history, but if not, these are some things you could look at. So acidosis, hopefully you got a shock off and hopefully that comes back quick. That'll give you a clue. Or you have something in the history, like if they're a DKA patient. But a lot of these respiratory cases, patients aren't ventilating that well, so any of them can get acidotic. Anaphylaxis, hopefully, you're examining them, undress them, take a look at them because they might have other obvious signs, respiratory signs like stridor or wheezing, or skin manifestations like urticaria. Tamponade, look at the monitor, take a look at what their blood pressure looks like, and take a listen to their heart. You might be lucky enough to see a full Beck's triad, which is the narrow pulse pressure, muffled heart sounds, and elevated JVP. And if you have ultrasound, obviously take a look for any pericardial effusion. Pulmonary hypertension, I like to also couple this with any signs of like increased right heart pressures. Very complicated intubating these patients, as Suvam alluded to. They can decompensate extremely quickly. It'll be a little bit of a diagnosis of exclusion, but you can get some clues into it based on the history and ultrasound findings. If a patient has stacked breaths, you can look at the vent tracings and that might clue you into it. Hypovolemia, look at their exam, whether it's they look very dry, they look septic, or there are traumatic injuries involved. You can do ultrasound, doing a fast exam, or taking a glimpse at their IVC. Certain induction agents can cause hypotension, tension pneumothorax, and electrolytes. And really quickly, these are just some of the quick temporizing measures you could do, and we'll briefly go into it. But whether you're adjusting the vent settings, giving direct treatment, performing procedures, or just giving fluids and or pressors or blood products. So keep in mind your rush exam. This is a graphic from Rebel EM that I thought kind of gives a nice visual presentation, but a lot of these things you do on a rush exam will cover each of those things that can hopefully help you narrow the diagnosis. So let's say you have a patient in DKA. You're lucky enough to have this information, so you know they're probably acidotic, but patient's vomiting, maybe they haven't taken their insulin in a while, they have Kussmaul breathing, and despite every management you throw at them, fluids, insulin drip, etc., they worsen, their mental status worsens, and then you start to notice they get lethargic, they start breathing shallowly, and they're not compensating any longer. This patient might have to get intubated if all else fails, and they might become hypotensive afterwards. So this is just to talk briefly about acidosis being a cause. So it can be very difficult. These patients have very complex metabolic statuses between the respiratory component as well as the metabolic component. Patients with severe metabolic acidosis typically compensate with a high minute ventilation, so they have an increased respiratory rate and tidal volume in order to blow off the excess CO2. But if they become fatigued and they can't compensate anymore, they then will start getting a combined metabolic and respiratory acidosis, which is really bad. So choosing ventilator settings in these patients will be really important, and they'll need very close monitoring. So you'll want to approximate what their pre-intubation compensation ventilation was. So you might want to go on a higher end of the tidal volume, like 8 cc's per kg, and a slightly higher respiratory rate, maybe like the upper 20s to 30s. But as Dr. Douglas pointed out of Pearl, in her experience, be careful not to make them breathe too fast or to have too high of a respiratory rate, because then it can cause breath stacking if they don't have enough time to exhale. These patients will need several post-intubation gases and vent adjust settings very regularly. Let's say you have a case of like an asthma exacerbation or COPD exacerbation. Patient comes in despite any home treatment they attempted. You give Duoneb, steroids, MAG, Epi, you put them on BiPAP, you try everything, and they continue to decompensate. Again, their respiratory rate and effort slows, they're not moving air, they start getting altered and hypoxic. You're getting to a point where you have no choice but to intubate them. And then they get hypotensive after. And this time you notice that the vent alarm starts beeping. You look at the vent, and these are some of the tracings you see. The vent may be alarming because of increased peak and plateau pressures. So here you have stacked breaths and or also known as air trapping. So each of these tracings will show on the top pressure tracing, you'll see progressively increasing end expiratory alveolar pressures, which is your intrinsic PEEP. On the flow tracing, you'll see incomplete emptying. So that upward curve that's coming back to baseline, that's below the middle black line, you'll notice that that does not reach back to baseline and that before the new breath initiates. And then on the volume curve, you'll notice that the end expiratory volumes continue to increase subtly. This can cause hypotension because it can impede venous blood return, because the venous blood has to overcome the intrathoracic pressure to return to the right heart. If the air trapping develops, it can increase the intrathoracic pressure, which can decrease venous return, which can therefore decrease cardiac output, cause hypotension, and if not treated, can cause arrest, or it can cause pneumothorax. In this case, you'll want to disconnect the vent, allow the patient to exhale, and then adjust their vent settings. So whether you're adjusting the I to E ratio, the tidal volume, or the PEEP. So this one, I'll just kind of go ahead because it's kind of similar to what the prior case. So let's say, again, you intubate someone, maybe you think they had air trapping, you try to treat the air trapping and it doesn't get better. This will be hopefully a quick diagnosis if you take a listen to their breath sounds, compare it to their initial exam. If you hear decreased breath sounds on one side, and or using ultrasound if you see signs of lack of lung sliding. Anytime somebody gets intubated, especially if they have high PEEP, So for example, somebody in ARDS that is very hypoxic, they might need high PEEP and FiO2 to maintain decent saturations, can cause tension pneumothorax. So obviously chest tube would be to treat that, and then adjusting vent settings accordingly. Anaphylaxis is one. It's pretty rare to get anaphylaxis from like these induction agents like ketamine, Tamponade. But you know, whatever you're giving them, any exogenous substance does have a possible to cause an allergic reaction, especially if you don't know the patient's history. So look for any additional signs, rash, angioedema, or if they have wheezing. Your treatment's obviously going to be your epi, your antihistamines, your steroids. Next would be Tamponade. Elderly patients. So some patients might have small pericardial effusion. So elderly patients on anticoagulants that have minor falls, or patients with ERCD might have borderline tamponade or fluid around the heart that only presents itself after there's a change from negative pressure ventilation to positive pressure ventilation. Again, from the increased intrathoracic pressure. So that could be diagnosed with a cardiac ultrasound, or again, just from physical exam and looking at the blood pressure in the monitor. Pulmonary hypertension and or like things that cause increased right heart pressures. This is a very broad topic, very complicated. These patients are extremely difficult to intubate. They're very sensitive to many things, but it's worth keeping in mind what's the cause of their increased right heart pressures. There's a grouping that's usually more for chronic pulmonary hypertension, but thinking about it can help you think about your differential of what's causing these increased right heart pressures, and things being like left-sided heart disease, pulmonary embolism, or lung disease. Here you'll want to try to treat the underlying cause of the increased right heart pressures. But like I said, these can be very complicated cases. Hypovolemia, usually it's a lot of our patients, especially in like septic shock. So looking for signs of severe dehydration, sepsis, or if it's traumatic, you could do a fast, look to see if there's any bleeding in the abdomen. They'll need either emergent surgery, fluids, pressors, blood products, replace the volume. Induction agents. So some induction agents have a side effect of a hypotension. So it can decrease vascular tone and venous return. Also, any sedative agent that takes away an individual's conscious drive to survive, meaning like their sympathetic response, can also lead to like hypotension and post-intubation collapse. Benzos and propofol can decrease sympathetic tone, which cause vasodilation. And in these critically ill patients, they're relying on their sympathetic response to maintain their cardiac output. And also changing from negative pressure ventilation to positive pressure ventilation, it can increase intrathoracic pressure, which can decrease venous return. So usually you want to think about your choices. If somebody's already hypotensive prior to intubation, you're going to want to avoid something like propofol. Usually ketamine is a good choice in these cases because it causes a little bit of a sympathetic surge as well as some pain control, which can help patients. And then lastly, electrolytes, most notably potassium, especially when giving something like succinylcholine. You have the risk of hypervolemia. Patients most at risk are patients with large burns, crush injuries, ESRD. But there are a couple case reports of patients without known risk factors that do develop hyperkalemia. So it could be a little bit of a diagnosis of exclusion, but try to take a look at the monitor as well. If you notice that they have any change in their rhythm, you could think of hyperkalemia. You might not have the labs, but pushing a little bit of calcium empirically probably has low risk to benefit ratio. And then really briefly, some additional points to consider. Some studies reported on the Rebel EM blog that I was looking at showed that, which is probably obvious, systolic blood pressure less than 90 is a risk factor for peri-intubation cardiac arrest. As best you can, try to resuscitate them as much before the intubation. Again, you might not be that lucky to have that time. So if you don't, you can make some PushDose pressors or start them on peripheral pressors. And really quickly, to make your own PushDose pressors, you could take the epi from, because sometimes the order from Epic takes some time for nurses to get. So if you have to make your own emergent push dose epi, you can grab a syringe from the code cart. And here you'll see that the code epi is 1 mg per 10 cc's. A little bit of math here, so which is 0.1 milligrams per cc, which if you just convert those units, it's 100 micrograms per cc. And I say that because your order from Epic is going to be, it's administered in micrograms per minute typically. So you have 8 milligrams in 250 D5W. And like I said, you'll administer usually a couple micrograms per minute. So what you're going to do is you're going to take a 10 cc saline syringe, waste 1 cc, and then add 1 cc, which is 100 micrograms of the code epi. And that'll make your syringe now have 100 cc's of epi in 10 cc's of saline, or in 10 cc's of volume, which then converts to 10 micrograms per cc. And that's kind of within that range of what you'd be giving from your bag. What did I do? Oh, your bag of epi otherwise. And then one other thing I thought, just thinking about like math, I don't know if it's possible, but if we had, and maybe some attendees comment, if we have a 250 cc of D5W, can we just mix our own really quickly, just withdraw 80 cc's and push 8 code epis into it, because then that'll give you exactly what pharmacy would be mixing anyway. Yeah.
I think you can do this as a quick, you can take the liter for the cold cardiac epi is, just start as a slow drip. I did it on the floor a couple times, but they didn't have the stuff done right away. And you just repeat the blood pressure every 2 minutes. And you just adjust the dip as you sit until you can get that accurate stuff.
Yeah, it's a lot of ways to make dirty epis. Cool. So that's it. Again, there's your differential. There's your mnemonic, but then at the bottom there's different shock, causes of shock, and all other causes of hypotension to also keep on your differential. So that's all I got. Thank you.